Good evening. Will the Standing Committee on Public Accounts please come to order? This meeting has been called to consider the following report: the Auditor General's Report, Addictions Treatment Services in Manitoba, dated July 2023. Are there any suggestions from the committee as to how long we should sit this evening? Emily Malloway.
Mr. Chair, we recommend that we sit for 1 hour, 15 minutes, and then revisit at that time.
It has been suggested that we sit for 1 hour and 15 minutes and revisit at that time if necessary. Is that agreed? Agreed and so ordered. At this time, I will also ask the committee if there is leave for all witnesses in attendance to speak and answer questions on the record if desired. Is that agreed? Agreed. Leave has been granted. I would also like to remind everyone that questions and comments must be put through the chair using third person as opposed to directly to members and witnesses. Before we proceed further, I'd like to inform all in attendance of the process that is undertaken with regard to outstanding questions. At the end of every meeting, the research clerk reviews the answer for any outstanding questions that the witness commits to provide an answer to and will draft a questions pending response document to send to the Deputy Minister. Upon receipt of the answers to those questions, the research clerk then forwards the responses to every Public Accounts Committee member and to every other member recorded as attending that meeting. Does the Auditor General wish to make an opening statement? The Auditor General.
Thank you, Mr. Chair. First, I'd like to introduce the staff members I have with me tonight. Tonight, I'm joined by John Stace, Audit Principal, and Jeanette Maillard, Auditor, both of whom worked on the report Addiction Treatment Services in Manitoba. Mr. Chair, substance use and addictions can have a devastating impact on individuals as well as those around them. Manitobans experiencing addictions issues are more likely than the general population to be accused of or become the victim of a crime. They are also more likely to visit an emergency department and much more likely to die before age 75. Effects on family members and others close to a person experiencing substance use and addictions may include emotional and economic burdens, relationship distress, and family instability. In this audit, we looked at whether Manitobans had access to appropriate addiction treatment services when they needed them. Mr. Chair, we found appropriate addiction treatment services were often not available to Manitobans when they needed them. More specifically, we found that capacity did not meet the demand for addiction treatment. As a result, people continued to experience long waits. These issues are amplified in rural areas and in the north, where some treatment options were severely limited. For example, only 14% of detox beds were located outside of Winnipeg. In addition, a fulsome system-wide picture of addiction treatment services in Manitoba did not exist. This is because the delivery of addiction treatment is decentralized, records are still largely paper-based, and data collection is siloed. This is further challenged by poor data quality. As a result, it's extremely difficult to track a person through the addiction treatment system. We also found there was a lack of coordination across the different types of treatment services. Different service providers, both in the public system as well as not-for-profits and private providers, need to work together and coordinate to provide treatment and care to individuals with addictions, regardless of how healthcare system is structured. This report includes 15 recommendations to improve the delivery of addiction treatment services in Manitoba. I encourage the Department of Housing, Addictions and Homelessness and Shared Health to work with all service delivery organizations to act on these recommendations to resolve the risks identified by this audit. I'd like to thank the many provincial government officials and staff and the many other stakeholders we met with during our audit. Their cooperation and assistance is much appreciated. I would also like to thank my audit team for their due diligence and hard work completing this report. I look forward to the discussion today on this report.
I thank the Auditor General for his opening comments. Does the Deputy Minister of Housing, Addictions and Homelessness wish to make an opening statement, and would she please introduce her staff joining us here today? Thank you. The Deputy Minister.
Thank you, Mr. Chair. Good evening. And thank you for the invitation to provide some opening comments and speak to the Department of Housing, Addictions and Homelessness's response to the Auditor General's report on addictions treatment services in Manitoba from July 2023. With me from the department, I have Nolan Amino, who's our Acting Director of the Mental Health Addictions Treatment and Recovery Branch, and Anne-Marie Hayek, who's a Senior Policy Analyst with the Mental Health Addictions Treatment and Recovery Branch as well. So I want to thank them for all the work that they've been doing behind the scenes, moving this forward as well. Ensuring individuals have access to appropriate addiction support and treatment services when they need them is a priority. It's a priority for the department, and we know it's been a priority for the government for a long time. I'd like to acknowledge the work of the Auditor General and his office on this audit. The audit provided an opportunity to examine some of the addiction services available in Manitoba, and it's provided and helped to strengthen the addictions treatment system to ensure Manitobans have access to the services they need when they need them. I'd also like to acknowledge our colleagues here from the department, my colleagues from the department from Shared Health, who are also joining us here today, Dr. Krista Dulo, Dr. Serene, and Ben Fry. Shared Health is an essential pillar in the healthcare system, and they bring expertise, coordination, and leadership to mental health and addiction service delivery across the province. As the provincial health authority in Manitoba, Shared Health has been a key partner in responding to the recommendations of this audit report. This partnership has been integral to supporting improvements in addiction services in our province. And by working together, we create a system that evolves and expands to meet the growing and changing needs of Manitobans. We will continue to work with Shared Health to address the recommendations to help support improvements in addiction services in the province. If I can take a moment just to provide committee members and others here with some context on the programs and services discussed in the report. The continuum of addictions treatment services and supports for adults in Manitoba includes access to addictions medicine through the Rapid Access to Addiction Medicine Clinics, or RAM clinics, as we'll refer to them, opiate agonist therapy, or OAT therapy, withdrawal management services, a variety of community-based services, day and evening treatment, short and long-term primary bed-based addictions treatment, outreach, aftercare programming, and supportive recovery housing. Much of this was covered in the auditor's report, but just to briefly recap, withdrawal management services provide support to individuals who want to withdraw from a substance they are using. They are offered through a few different models, including hospital bed-based medical withdrawal management services, non-medical community bed-based withdrawal management services, and mobile withdrawal management services that can be accessed in a person's home or other safe place. RAM clinics provide walk-in assessment, counseling, prescription of addictions, medication, including OAT therapy, as well as referrals to withdrawal management services, community treatment programs, and primary care physicians. Day and evening treatment programming is available for people who require intensive treatment but wish to return home to sleep. And bed-based intensive primary treatment services are provided through service delivery organizations and several community service providers. These programs provide structured live-in treatment and last anywhere from 28 days to 3 months or more. And then finally, supportive housing, recovery housing provides longer-term accommodation in a stable, supportive, substance-free environment to individuals who have completed addictions treatment. Publicly funded substance use and addiction services and supports in Manitoba are provided by Shared Health, regional health authorities, nonprofit community organizations that receive government funding, the federal government, and First Nations communities. Services may also be provided by primary care providers, such as family physicians or walk-in clinics, and private for-profit addiction treatment agencies. The July 2023 OAG audit of addictions treatment services examined services provided by government service delivery organizations in the Winnipeg Regional Health Authority, Prairie Mountain Health, Northern Health Region, and Shared Health. Just one thing I would note, by no means intended as anything other than additional context, is that because the audit focused on provincial services and did not include the community-based services, private provider services, First Nations, or those funded by the federal government, it gives a good look and indication into what the system is in Manitoba, but not the full picture of all the services available and the impact of those services on capacity to deliver as well as wait times. And so just flagging that as as a contextual piece. And that broader perspective, of course, is important because community agencies play a very big role in delivering Manitoba's publicly funded addiction services. I think one thing I'd also like to note is just that harm reduction is a key pillar in any comprehensive addiction system. We know that substance use and addiction are multifaceted and complex and follow a spectrum of service and treatment. Harm reduction services tend to reduce the health and social harms associated with substance use and play a key role in preventing overdose, limiting disease transmission, and keeping Manitobans connected to care. And those services are important to consider in the context of Manitoba's addiction services system as well. The audit covered the period between July 1st, 2017 to June 30th, 2022, with a detailed review of the 12 months ending June 30th, 2022. In 2023, the department expanded and changed to include the portfolios of housing and homelessness. I think this is just important context to have in terms of the work that we're doing today, because addressing homelessness is particularly complex, and the need for accessible and responsive addictions programs and supports has really never been greater. This requires coordinated, multifaceted responses to address the depths of these social challenges effectively. The mandate of the department continues to support a coordinated approach to ensuring the safety and well-being of our province's most vulnerable individuals, and that recognizes the connections between addictions and homelessness. Since the conclusion of the audit report, the Government of Manitoba has been responding to the recommendations in the report and has made significant progress in addressing many of the findings. We have a steering committee co-chaired by Housing, Addictions and Homelessness and Shared Health that's been formed to provide oversight and coordinate those efforts and to address the strategic initiatives. Housing, Addictions and Homelessness has been working with Shared Health and service delivery organizations to track the progress on each of the 15 recommendations, and I'm pleased to report that together we've partially or fully addressed 14 of the 15 audit recommendations since 22-23 through structural changes and capacity increases. Some examples of initiatives that are complete or are in process that support several of the audit recommendations include drafting of the substance use and addiction standards for adoption by publicly funded bed-based addiction services, implementation of the accountability and performance management framework, the access intake assessment and coordination project, and needs-based planning. The one recommendation that requires, I think, some further work and additional focus is recommendation number 4, that we adopt an electronic records management system for addictions treatment services and ensure that all addictions treatment providers are using the same system. This work is ongoing, and we continue to work with Shared Health in that regard. We certainly agree with the recommendation and see it as a priority. In addition to the progress that we've made with the audit recommendations, the Government of Manitoba has made significant investments to increase access to services and supports, including expanding the capacity of RAM clinics, various levels of withdrawal management services, opiate agonist therapy, short and long-term addiction treatment, supportive recovery housing, and outreach and intensive day programs. We're also working with our partners to bolster our harm reduction response to reduce overdoses, and this includes distribution and disposal of harm reduction supplies, and also includes drug checking services that reduce the harms associated with a toxic drug supply. We also work closely with public health to ensure Manitobans have access to naloxone in the event of drug toxicity or overdose through Manitoba's take-home naloxone program. Again, we're committed to improving the addictions treatment services system for Manitobans. And I, again, want to thank the Auditor General for this important report and believe we've made significant progress on 14 of the 15 recommendations, and pleased to have the opportunity to answer any questions from the committee.
I thank the Deputy Minister for those opening comments. Does the Interim President and Chief Executive Officer of Shared Health wish to make an opening statement, and would he please introduce his staff joining him here today? The CEO.
Good evening, and thank you, Mr. Chair, for the opportunity to present and answer questions related to Shared Health's work in response to the Auditor General's report, Addictions Treatment Services in Manitoba, dated July 2023. My name is Dr. Chris Christodoulou. I'm the Interim President and CEO of Shared Health, and I'm joined this evening on my right, Dr. Jitender Sareen, right behind me here, the Provincial Psychiatry Specialty Lead for Shared Health, and also the head of the University Department of Psychiatry at the University of Manitoba. Ben Fry, to my left, is the Chief Operating Officer for Mental Health and Addictions within Shared Health. And I'm pleased to have this opportunity to update the Standing Committee on Public Accounts as it relates to the Office of Auditor General report on addiction treatment services in Manitoba. I'd like to thank the committee for the opportunity to provide comments and respond to questions and offer our gratitude to Auditor General Tyson Shaikello and the Office of Audit Professionals. I want to acknowledge their professional and collaborative relationship with Shared Health and our staff. These reviews are both rigorous and complex and are welcomed by Shared Health to not only highlight what is going well, but more importantly, to identify areas for improvement. The issue of addiction remains a significant one in Manitoba. Over the past few years, we have seen a significant increase in the demand for addiction services throughout our province. In addition, the complexity of challenges faced by those seeking care has risen substantially as we see an influx of more potent and often toxic substances into Manitoba. In the past few years, the mental health and addiction system has undergone significant reorganization with the primary goal of meeting this increased demand and improving services for patients and families. This includes providing timely access to services through evidence-based assessments and matching Manitobans to the services that address their addiction and substance use needs. This can be a combination of 24/7 services such as in-house treatment facilities or outpatient services like medical clinics that focus on withdrawal options and counseling, such as those provided in rapid access to addiction medicine clinics across Manitoba. The Office of the Auditor General report contained 15 recommendations. Some of those were directed to the Department of Housing, Addictions and Homelessness Department, while others were focused upon Shared Health and our Shared Health and regional health authorities. There are several of these recommendations with shared responsibility between both the department and Shared Health. We are pleased to share that of the recommendations directed to Shared Health, one has been fully addressed, while significant progress has been made on the remaining items. The recommendation that is fully addressed, recommendation number 3, Shared Health coordinate learning and conferencing opportunities for all service delivery organizations, employees providing addictions treatment, as well as government-funded non-profit service providers. The recommendations still in progress, and I will just list the number here for the committee, are items 2, 9, 10, 11, and 14. The aforementioned recommendations, there were multiple themes throughout the OAG report, many of them centered on reducing barriers for Manitobans to access the necessary supports and care that they need, the importance of collaboration across the service system and embracing interventions that work was also stressed in the report. This includes strengthening the role of the RAM clinics, access to medical withdrawal services, and ensuring that we are recruiting and retaining professionals who specialize in addictions medicine. I wanted to highlight virtual options for a moment. The Rapid Access to Addictions Medicine digital front door program enables clients to access these services by using either their laptop, a tablet, or a phone. The experience is similar to using WhatsApp, FaceTime, or Instagram accounts. Recent expansions of cognitive behavioral therapy also help Manitobans to access free therapy and coping strategies virtually. By providing these options, we are reducing barriers to care that people may experience in accessing those mental health and addiction services they require. There are mobile withdrawal management services in operation within Prairie Mountain Health and Southern Health, Santé Sud, while Clinic Community Health operates a mobile service within Winnipeg. The Aboriginal Health and Wellness Centre, RAM Clinic, launched a mobile clinic in July of 2024. The planned access intake assessment service for mental health and addictions will also move to a more streamlined one-stop shop for Manitobans seeking services, and will improve waitlist management and improve matching of clients to services that are required. The coordination of learning and conferencing options was also highlighted in the report. One such example is Project ECHO, which stands for Extension for Community Health Outcomes. The project functions to connect providers from across the province to increase collaboration, strengthen addictions medicine competencies, and thereby improve service delivery to our clients. Looking more broadly, there are important efforts underway to also improve the experience for adults accessing the addiction services systems. This includes ongoing investments from the Manitoba government in housing addictions and homelessness in particular. In 2024, a review and redesign of the community mental health and addiction services with a particular focus on clinical and treatment services delivered in the community and outpatient settings was commissioned. The committee tasked with this work is in the process of completing a report that will identify potential opportunities to further enhance community-based care. Additionally, work to develop a mental health, substance use, and addictions system strategy for Manitoba youth will commence in the coming weeks with similar goals. Thank you for your attention tonight, your interest in this important public health issue, and your ongoing approvals for funding from government to current and expansion of services for all Manitobans is greatly appreciated and welcomed. Thank you.
I thank the CEO for his opening comments. The floor is now open for questions. Emily Owasco.
Thank you, Mr. Chair, and I'd like to thank the department and of course, Shared Health for attending today as well, and thanks to the Auditor General for bringing forward your report. So I'd like to ask through you, Mr. Chair, can the department expand on some of the RAM clinics information, if they can touch on where the current RAM clinics are, when did they open, and what's some plans for future locations?
The Deputy Minister.
Thank you, Mr. Chair, and I thank the member for the question. There are currently 7 RAM clinics in Manitoba, 3 in Winnipeg, and 1 each in Selkirk, Brandon, Thompson, and Portage-la Prairie. Virtual services have also been launched using nurse-led digital front door clinics to expand accessibility more widely across the province. Hours of operation vary somewhat by location, with most clinics open 5 days per week and physicians available for defined clinic times. Saturday services are also offered by 2 Winnipeg clinics, Crisis Response Center and Aboriginal Health and Wellness Center. And I appreciate the member asked a question about the opening of the RAM clinics. I don't have those dates with me. If we can undertake to get that information back, happy to do so.
Emily Owasco.
Just a quick follow-up. Thanks to the Deputy Minister for the answer. And then thank you also for the upcoming information that'll be brought forward in the future. Is there, according to the Auditor General's report, is there plans for future ones that you can talk about?
The Deputy Minister.
Thank you, Mr. Chair, and again, thanks to the member for the follow-up question. And I want to say I appreciate the caveat of what you can share and understanding that. I don't have anything specific that I can commit to as far as future expansions at this point. But what I would like to add is that ensuring individuals have access to appropriate addiction support and treatment when they need them is a priority. And I think that we've seen real success with the RAM clinic model and continue to see increasing numbers of people accessing those supports. The continued investment in RAM clinics and the addition of virtual services through the digital front door that Dr. Christodoulou had mentioned, and the Northern Referral Pathway is providing more access to RAM clinics through different means than walk-in only. And so I just wanted to reiterate that, as well as the education initiatives that are ongoing to increase addiction medicine capacity within primary care, including the RAM Knowledge Exchange and the ECHO program that, again, Dr. Christodoulou had mentioned in his opening comments as well.
Emily Compton.
Thank you, Chair. One of my always first questions is around data. And that was one thing the Auditor General really lifted up, and the nurse in me, I can't help but ask for the evidence and data and stuff. And I know that was a serious critique of lack of data, poor data tracking, all that kind of stuff. So I'm curious what has been put in place or is being put in place for better data collection of what is, as well as informing, our actions getting the results that we want, or do we need to, tweak whatnot?
The Deputy Minister.
Mr. Chair, and thank you the member for her question. Data is currently being collected through the Shared Health Data Exchange portal, which enables standardized data submission across all the service delivery organizations and community agencies. There are 10 key performance indicators that are currently being collected, including wait times, service utilization rates, and occupancy metrics. The portal collects data on 4 indicators, while the remaining 6 indicators are reported through the Provincial Information Management and Analytics Unit. The APMF management framework is already implemented with baseline data collection and analysis underway. Complete refinement of the framework is anticipated by the second quarter of this year, and the framework's already operational and providing valuable system performance insights internally, even as the department continues to refine and enhance its capabilities. And I would echo the importance and support for good data in this work, and for good data to drive evidence-based decision-making when we look at increasing treatment services and recovery services for individuals. So that's something that I think our shared areas have been working very hard on, and will continue to refine and strengthen as time goes on.
Emily Brar.
Thank you, Chair. My question was stolen, actually. I had the same question, so thank you. That saves time. I would ask a general question. Before that, I want to say thank you to the AG office, thank you to the department for what you're doing for Manitoba. And I also want to welcome friends from Shared Health. I have a general question. The report talks about barriers to treatment services, talks about few services in rural and northern areas, lack of capacity and coordination for opioid agonist treatment. So I want to ask simply, between when the report was done and now, what kind of improvements, maybe infrastructure improvements or staffing improvements, or some barriers that we were able to remove? So what's the update on that?
The Deputy Minister.
Thank you, Mr. Chair, and again, thank the member for the question. Certainly, barriers to access are well acknowledged, and some of the significant ones I think that we've seen through the department relate to geography. Rural, northern, and remote communities in particular in Manitoba, as is often the case with service. And so we are working to increase capacity for addiction services and supports in each of the 5 health regions to enable Manitobans to access services close to their home communities. We have RAM clinics in every region now. We have mobile withdrawal management services as well as medical withdrawal management services in every region. So that's, I think, significant. The awareness of services is also tends to be a barrier to access, and that's being addressed through updated shared health and regional health authority websites, Manitoba Addictions Helpline, Manitoba 211, along with the work we're doing around access, intake, and assessment and coordination. The other piece is stigma. And this is, so this is also being addressed through the development of standards and training for service providers. I think that's a really important thing. We're still seeing a lot of that in community, let alone with providers. And it's being addressed through the provision of harm reduction supplies and services in communities, and in partnership with the service delivery organizations. And one other noteworthy piece I would say is we also now have 320 opiate agonist therapy providers that are trained in the province as well to prescribe OAT. And so those are some examples of things that have increased in the last period.
Emily Brar.
Thank you, Chair. Thanks for that information. When we talk about awareness and stigma, it reminds me about ethnic communities and new Canadian families. There is way more stigma in some particular communities, I would say. Is the department considering using some ethnic media or other tools to make those communities aware about mental health issues? In some cases, people do not even consider that this is mental health. So is there something on the table to information dissemination, creating awareness to those particular groups?
The Deputy Minister.
Thank you, Mr. Chair. And thank you again for the question. It's an excellent question. It's a fantastic point around the not just the diversity of communities in Manitoba, but how those communities experience substance use, addiction, mental health, I think is really something that we pay close attention to. And we fund a number of organizations to serve different groups, whether they be 2S, LGBTQ populations, diverse groups, newcomers, Indigenous communities. And so, again, I thank the member for that question. There's a few things that we do fund some organizations and work with a number of newcomer organizations, such as Resilia, previously known as Aurora. Both our department and Shared Health fund Resilia, who provide trauma support, counseling, substance use support, and other mental health services specifically to newcomer groups. And so that's one example of where we are providing that support. I think it's also worth noting that the Access Intake Assessment and Coordination Initiative, in the future, the portal will allow for people to identify what groups they come from, should they so choose. So we'll be able to collect more demographic information than we do now, and I think that gives us real opportunity in the future to then again use that data to better target outreach to specific community groups. So there is some work being done now, and we do fund some, but I think your point is a really good one around making sure that we stay in touch with all of the diverse groups that we work with, making sure they get the information that they need.
Emily Brar.
Not a question, just a comment. In my experience interacting with such organizations, recently I got a chance to attend a few events organized by Healthy Muslim Families and Punjabi Community Health Services, just to know two of them. So they're doing great, so could be considered. Thank you.
Emily Compton.
Thank you, Honorable Chair. I have a question around the one recommendation that's still in action, but is ongoing, the adoption of electronic health records. I'm curious if they're thinking around, is what's happening, what type of record? Is it going to be something that's integrated throughout not just the mental health addictions component? Is it something that's going to connect in with the whole system? I say this as someone that comes from a program that literally I would be documenting between 2 different electronic records and paper stuff for one patient. So I'm just very curious around what the plan is or is looking like for the electronic record component.
The CEO.
Thank you, Mr. Chair. I'd like to thank the member for this excellent question. The digital health unit within Shared Health Services is on a roadmap to achieve implementation of a digital electronic clinical record for the 63 acute care facilities in Manitoba. And that roadmap is on track for September of 2027 to have the project completed. Now, there are multiple projects within this big project, and that includes updating all the emergency department information systems across all of these acute care hospitals. There's the building of the clinical documentation component of the electronic clinical record, so that whether you're in Flin Flon, Manitoba, or Winnipeg at the Health Sciences Center, that providers can see your information across facilities. The third portion is what is known as the clinical formulary. So when an order is placed and entered into the system, that our pharmacy colleagues can access that and dispense that medication on the wards to assist the patient with their pharmaceutical needs. All of this is integrated, and all the information captured within this digital electronic clinical record, and we have multiple sites that already have this established, both within Winnipeg as well as in Brandon and Prairie Mountain Health. All of this information is then hosted in the e-chart, which is accessible from all primary care offices. We recognize that there are multiple different electronic solutions that private vendors have undertaken and invested in over the years. But phase 1 of this project is to get all the acute care hospitals on one single system to address the very concerns about disparate recording that has implications for patient safety, because whenever there's a handover or wherever a patient needs to be transported from one hospital, let's say you arrive at the Victoria Hospital, you have a cardiac issue, you have to go to St. Boniface Hospital, handovers of care are points of vulnerability, and this one solution will address that. And on a go forward, the intent would be to start onboarding all the other community providers so that we have information integrated on one single system.
Emily Wasco.
Thank you, Mr. Chair, and I appreciate the department and Shared Health for your answers. So again, sort of going along the lines of what my colleague from Tuxedo has mentioned, when we talk about recommendations 4 and 5 in regards to data collection, all of that, we know already that whilst the report was getting done by the Auditor General, you did relaunch the Pathway to Mental Health and Community Wellness framework. Taking a look at the recommendation number 12, which is the standards, you've already started to create those standards and start implementing them. I guess when we talk about and I'm just quoting from your response, in 2023-24, all addiction service providers that receive government funding will be required to meet the standards to receive ongoing funding. How many total service providers are there, and how often are we going to check with them to do a bit of a shoulder check as far as how are they meeting those standards, and not necessarily to punish, but just how to support and help them in their potential lacking of following those standards?
The Deputy Minister.
Thank you, Mr. Chair, and thank you again to the member for the question. I just want to add a little clarification to that those standards are applicable to bed-based treatment organizations, withdrawal management, treatment, and supportive recovery housing providers as well, so not the full continuum of addiction services. We have about 35 organizations that are expected to adopt the standards, and they are all in process of doing so. The requirement to adopt the standards are embedded in their funding agreements, and because this is, you know, in process, we are in regular, department is in regular communication and contact with all those providers to support that adoption, answer any questions, and continue to support them to fully adopt.
Emily Malloway?
Well, thank you, Mr. Chair. Electronic health records really caught on in the United States in the 90s, I think probably because doctors get sued there, probably way more than they do here. But the Philman government started a smart health program with IBM in the 90s, and we made fun of it a lot, but it was like $50 million in developing this record, and I don't know how much success they had. But a few years later, St. Boniface Hospital had some sort of a electronic health record. Now you're making reference to you're developing another program that is going to be fully set up 2 years from now. So I'm wondering if you could tie all these things in. Like the government went on SAP in 92 or 93 so that we did have one standard. And at one time, before Philman amalgamated all the hospitals into Smart Health, you had these hospitals basically telling the government what they were going to do. They had their own cooking, they had their own computer systems, they had everything. And he had to go and practically threaten them that if you're going to take them out, take the boards over, if they didn't smarten up and go with the one. Because whatever system we had, it was always going to be cheaper if we put them all on the same one, okay? So we went with SAP. Now, did the hospitals ever go with SAP? Were they part of that program? So maybe you could kind of update me as to how we got to where we are now.
The CEO.
Mr. Chair, I'd like to thank the member. It's a wonderful question. The solution that Manitoba is putting forward that is building on the 2008 implementation at St. Boniface Hospital, which, as you correctly pointed out, was the first site to launch an electronic record, is with the same vendor. So we will have one single vendor that is providing the product for all 63 facilities across the emergency department information system, the clinical documentation, as well as the order entry. I'm happy to share with the committee that the vendor is Canadian-owned and that all the information is housed within Canada as it relates to those servers. The scalability and the affordability of this solution has been well researched by our digital health partners at Digital Health, and we're confident that the solution will meet the needs of Manitobans in our acute care facilities. There are multiple additional modules that come with this electronic clinical record that include all of the ambulatory clinics. It includes all laboratory and diagnostics, X-rays, CT scans, MRIs, echocardiograms. All information is visible to all the providers that have access across the system. So we're not looking at disparate systems from multiple different vendors. We've identified one vendor that has a product that meets all of our needs. We know that they have integrity as an organization and have been a tremendous partner to advance our initiatives. And yes, it's a tight timeline, but we're confident that our digital services at Shared Health can deliver on this product.
Just a gentle reminder to put questions and comments through the chair. Emily Malloway.
And thank you, Mr. Chair. Just a quick follow-up on that. So when you go to the doctor's offices today, you see that they still got their paper files, but they're more for show now, I think, because they don't ever go look at them. But they've got their little computers in their office. But they're only able to show you what you're doing with their office. They can't tell you what you did at somebody else's office. So is that all part of the same system here, or is that a different system?
The CEO.
Yeah, I'd like to thank the member for that great question. So private practitioners working in the office clinics, many of them have different electronic clinical records that have to conform to the standards for electronic procurement systems that are set by Digital Health. Those individual providers are able to access the e-chart. So this is the Digital Health approved e-chart. So if you've presented to St. Boniface Hospital, I'll use that as an example, you've gone to the emergency department with chest pain, your laboratory, your investigations, the report that the emergency room physician has entered in is all accessible from that office. So they may use a different system to record their visit that you're having with the provider in that particular clinic, but your global information that once you've accessed an acute care hospital is accessible and available from any point, and all Manitoba providers have access to that. So there is obviously an array of systems that people implement, just like there are different charting systems that people implement, but this electronic chart that is fed by information that we collate from all our hospital systems is integrated, and it does become a one portal for them to be able to access your information, which is where we need to be for all our patients and families.
Emily Compton.
Thank you, Chair. One of the things I'm curious about, and my colleague across the way, Emily Brar, talked around stigma in specific communities, ethnic communities and stuff. I'm actually curious around how the work is going with working on the stigma within the medical practitioner community. Because when I say medical, not just doctors, like how are the changes that have happened in the last, since this report came out, how is it going with maintaining treatment when folks have to access, maybe for non-addiction reasons, the healthcare system? How is that becoming a barrier to people having their treatment continue? I just speak as someone who I've known about harm reduction since nursing school in early 2000s, right? This is not a new concept. It's a strong evidence-based, proven way of helping people. I've worked with pregnant women on methadone treatment, stuff like that. But I also know have worked with many colleagues that have their own concerns and their own misunderstandings. And so I'm curious if that is something that is being worked on as we're updating how we treat folks, how our systems work. Are we identifying where there's barriers within our own system that get in the way of people's treatment that they may already be accessing? Does that make sense?
The CEO.
Mr. Chair, I thank the member for this great question. I would like to defer the response to this question to the Provincial Specialty Lead for Psychiatry for Shared Health and the University Head of the Department of Psychiatry at the University of Manitoba, Dr. Jitender Sareen.
Thank you.
All right, the provincial lead. You have the floor. Go ahead. The Provincial Specialty Lead for Psychiatry. You have the floor.
Thank you for the opportunity to speak, and thank you for the excellent question. I think first I want to acknowledge that stigma still exists in our healthcare providers as well as in the population. I think there has been lots of improvement and reductions in stigma because of a number of efforts that have occurred in providing education to providers on how treatments actually work for substance use disorders. So, for example, alcohol use disorder and opioid treatments are treatable, as you're saying, and harm reduction approaches. So there's been a systematic effort within our knowledge exchange events, as well as in our educational programs in all healthcare providers, including nurses, social workers, as well as engaging peers in the recovery. We have this program called Extension of Community Health Outcomes, which really emphasizes and works on linking providers with specialists in educating around both treatments but also recovery pathways. And we've done a number of different events. Our aim is really to recruit and ensure that people are aware of not only in outpatient services, but on inpatient as well as emergency settings, and really aiming to work on programs that really reach rural populations as well.
Hearing no further questions or comments, I will now put the question on the report. Shall the Auditor General's report, Addictions Treatment Services in Manitoba, dated July 2023, pass? This report is accordingly passed. Before the committee rises for the day, I would ask. The hour being 7:32, what is the will of the committee? Committee rise.